Welcome to week 5. We have 3 topics for this week, one really big one that you'll definitely see, and then a couple of others. Trauma and stressor disorders, dissociative disorders, and somatic symptoms or somatic disorders are our topics for this week. Trauma is by far the biggest area that you're going to see in your practice. So it's pretty much guaranteed that you're going to see clients that have trauma-related issues, that have had traumatic events in the past. So this is an area that you need to be very familiar with. When you take the 630 class, if you have not done so already, you will spend a lot of time looking at trauma, reading Vander Kolk's book on trauma, and finding a little bit of information on how to start working with clients who have had traumatic histories. So this is an area you definitely want to spend some time with, especially with a PTSD diagnosis. So when we're looking at the trauma and stressor-related disorders, these are disorders in which there has been some exposure to traumatic or stressful event, and that has to be part of the diagnostic criteria. So without that exposure to the traumatic event, it's not going to fall into this category. You're going to be looking at a different kind of diagnosis. You will see a very close relationship to anxiety disorders, obsessive compulsive disorders, and dissociative disorders. That close relationship might mean that you have co-occurring diagnoses with any of those or multiple different diagnoses in those categories. Some of the main things that you're going to see in general is going to be the inability to experience pleasure, or the dysphoric sense of unease, dissatisfaction. Somehow things just aren't right, but you can't label how. You might see some externalizing angry and aggressive symptoms. So especially in kids, you're going to see a lot of kids acting out, being very aggressive, being perhaps violent, and they might not even know why. And you're also going to see some of those dissociative symptoms where people simply can't remember some of the events that happened. So we're looking at the DSM through that timeline again, starting with things that come about at the younger age periods. And the thing that you're going to see mostly and only at the younger age as far as a first time of diagnosis is the reactive attachment disorder. Wendy used to do private practice with kids who have this diagnosis. So if you want to learn a little bit more from a personal perspective, she would be a great person to go and talk to. I know people have talked to her in the past about their papers when this was their topic. So if you want to look at page 265, a couple things that you're going to see is that consistent pattern of inhibited, emotionally withdrawn behavior towards adult caregivers. So the primary thing that you're going to know is going into this category of a diagnosis is that there's no attachment between the child and the caregivers. So this could look like a couple of different things. It could be that the child doesn't go to or attach to anyone, or it could be the other side where the child will run to sit on anyone's lap without distinguishing between caregivers and strangers. So it could go either way. This is one of those categories where you have to have that traumatic kind of experience in the past. For kids with a reactive attachment disorder diagnosis, what this is going to look like is some form of insufficient care. So we're not really looking at abuse as much as we're looking at neglect. So maybe the parents left the child home all day by themselves when they were 2 years old, or they just never picked them up or touched them, or they never did that kind of bonding information, the bonding patterns that you see most parents will do with their kids. This might also look like kids who have a lot of different caregivers. So maybe they're removed as an infant, they're put in foster care, they're moved from home to home. That would be one of the examples that we see fairly often with these kids. Something in these areas, and sometimes it's something that you might not even think about as much. So maybe at 6 months, the child was removed from the mother's care, placed with relatives. It didn't work out so well with the relatives, so then they're moved into a different form of foster care. Those are the things that we're going to see. And these patterns have to have happened before the age of 5. And you're going to see some of those patterns of not being able to connect with people by that age. So remember that neuroscience book that you read in 630, if you've had that yet. We were talking a lot about how the mirroring of the neurons between the mother and the child is what helps that child be able to form the emotional regulation capacity. That's what helps them know, okay, they're not reacting, so this isn't a big deal, or they really reacted to the situation, so this is something that I need to be concerned about. If kids don't have that experience, they don't know what to react to and what not to. You might also see this co-occurring with developmental delays. So that could be a cognitive, it could be a lack of language, so kids just don't have the language to speak or to share with other people. Prevalence is unknown. You're going to hear the DSM say that it's rare. You're going to hear clinicians say that they see this all the time. So there's a bit of a debate as to why that happens. A lot of people think this is very highly overdiagnosed, so that whenever there's an issue with some kind of neglect in the past, you see the kid acting out or not having that appropriate relationship, people are automatically assigning them a diagnosis of a reactive attachment disorder. That's not necessarily always the case, and we need to try not to overdiagnose this. One example of this that you will see a lot of, or might have heard a lot of stories about, would be kids that are coming from orphanages, especially from what was called Russia and from Eastern Europe. So we heard a lot of stories when people that are probably now about 20 years of age, but about 20 years ago, stories of orphanages where the kids were put into a bed and just kind of left there, left in the crib all day. There wasn't enough staff to give any of the kids individual attention, so the kids just sat there and didn't have any connection with other people. And a lot of the kids that were adopted into the United States that came from that background ended up with this kind of attachment disorder because they just didn't have that connecting time with a parent or a caregiver. So the important thing is that it's a caregiver, one specific person. Obviously, it can be multiple people as long as they're consistent. But we have to have at least one person giving consistent care to be able to keep this from becoming a diagnosis. Very interesting one if anyone wants to look at it for a final paper or EBP if they haven't done that yet. Okay, post-traumatic stress disorder is probably one of the diagnoses that you're going to see a lot of. It's something that you're going to have come into your office fairly often, no matter where you're working. If you're working at any kind of CMH or public health center, you're going to see this a lot. So this is an area where the person has to have had some kind of traumatic event. So it could be really anything that causes them to believe that their life is in danger. You hear a lot about everything from hurricanes, tornadoes, so natural events like that. Abuse and neglect could fall into this. A sexual assault would definitely fall into this. Seeing a caregiver or someone very, very close to you go through a life-threatening event could also be a part of this. So if you're a child and you see your caregiver abused or murdered in front of you, that would be something that would also cause you to doubt your safety. So that would definitely count as a traumatic event. You're going to see a lot of symptoms that might include intrusive thoughts, so those thoughts that you just can't stop thinking about the event. Dreams, disturbed sleep, not being able to sleep. Dissociative reactions that might include not being able to remember the event, or it might include having flashbacks of the event. And flashbacks are when the person feels like this traumatic event is happening to me again right now. So it's not simply a memory, it's when the person actually feels like they're stuck with that event happening again. So sometimes it can be very difficult for people in the middle of that reaction. When they're having a flashback, they might not recognize who you are, they might not be able to say where they are, and they might have a lot of difficulty breaking out of that flashback to understand what's happening now. You might see a lot of avoidance of triggers, so anything that reminds them of the traumatic event is to be avoided, and that can be things that they don't understand are triggers as well. So an example that I like to use is maybe there's a candle burning in the room, and maybe it was a vanilla smelling candle. So if in the future that person comes in contact with that scent, of the vanilla smell, that might trigger them into remembering what happened to them or into a flashback. They may not recognize that that vanilla smell is what took them into that flashback or what triggered them, because it's not something that's necessarily obvious in the situation, but it's something that is connected to the memory in the brain. Hypervigilance is also very common. You hear stories of war veterans that come back and a car backfires or someone drops a book and they jump, and maybe they jump under the desk or under a table because they think it's gunfire. So that would be an example of hypervigilance. Also, actually is a good example of having that heightened sensitivity to potential threats. So you might also hear people say that they always have to sit in the corner of the room so that they can see the entire room, or that they have to sit near the door so that they have a quick exit escape. So those are some of the kinds of examples that you're going to see in your clients. Trying to think of a good example of a client I've had. When I worked at the YMCA, I worked with actually a sibling group that had all been through sexual abuse, and they all reacted very differently, even though they all were diagnosed with PTSD. So the two that you might, kind of the two ends were shown in two of the girls. So the younger girl was about 12, and she was very kind of outward going. So she would react very angrily. She would have the flashbacks. She was always paying attention to everything around her. So kind of an aggressive variation of this. The older girl was about 16, and she was much more internal. So she would have a lot of the dissociative reactions, she would have flashbacks, and she would become very quiet, and people didn't know that she was quiet because she was actually reliving the event in her head. She actually had a lot of social anxiety too, so she got to the point where she didn't like to leave the house, she didn't like to go to school because that felt too dangerous to her. So this can look very different in different people. If you're working with young children, yes, young children can be diagnosed with PTSD. There's really not an age range for this. It's unlike the reactive attachment disorder is only for that specific age range. With PTSD, it can be pretty much any range. But notice that there are different criteria for kids that are 6 years and younger, so make sure you take a look at that if you're working with kids that age. Also notice that you might see some regression. So you might have kids that start off developing really well, and then they have a traumatic event happen, and then they regress a couple of grades, or maybe they lose their ability to speak at the level that they had. So be aware that that can happen as well. You might, wow, this actually sounds a little low to me. Lifetime prevalence of about 9%. I actually think it's probably higher than that. It's definitely seen more often in females. I don't know that that means it's happens more often in females, but females definitely come into treatment more often for this. It might be also a little bit higher because of the high amounts of sexual violence towards females in society. Anyone with PTSD, make sure you're assessing for that suicidal ideation and suicide attempts. That's going to be fairly common, so you need to make sure you're looking for that. Lots of different areas of disability, so it might be social, like the 16-year-old client I was talking about where she didn't want to speak to her friends anymore. It could be occupational, like she didn't want to go to school anymore. You might see physical disabilities or high medical reaction too. So when we talk about the somatic side of it, imagine people having physical symptoms related to all of this. People with PTSD are 80% more likely to have symptoms that meet criteria for at least one other disorder. So you're going to be looking a lot at depressive disorders, anxiety disorders, and substance use. You're going to see those a lot. If you're looking at males, you're going to see conduct disorders a lot too. So PTSD is generally after 2 weeks, right? 2 weeks to a month. Acute stress disorder is that 3 days to 1 month. So that time period that's before PTSD, you're really looking at a month after the exposure to the traumatic event. Acute stress, you're looking at a couple of days after it's happened until it's diagnosable for PTSD. So you're going to have some kind of anxiety response, some kind of re-experiencing, some kind of reactivity to a traumatic event. You might also see again that heightened sensitivity to potential threats, depending on what kind of situation that happened to them. And again, you're going to see this a little bit more often in females. So the thing to think about with this is really the timeline. So when did the traumatic event happen? If it's less than 3 days, you really don't want to diagnose them at all. It's going to be a normal reaction to the abnormal situation. But if it's gone beyond 3 days, you want to be able to treat them so we can use this as the diagnosis for that. After the month, you're going to switch the diagnosis to PTSD, or they might not need to have a diagnosis. It might go away within that month. So they might have the ability, especially with some assistance, to stop having reactions within that period of time. Adjustment disorders are a really wide range of things. So this is when we're looking at not necessarily a traumatic event, but we're looking at some kind of stress event happening in a person's life. So this can be anything from a child's parents getting divorced, a person losing their job, losing their home, moving across the country. Something of that nature could be enough to be that adjustment disorder kind of stressor. One of the things we're looking at is that the reaction is out of proportion to the event, or there's a significant impairment. So if the child is so disturbed by the parents' divorce that they are doing poorly in school, whereas before they were doing well, that would be a significant impairment in the school system and their school ability. That would be enough for a diagnosis. Keep in mind that this is something we're going to use when there's not another mental health disorder going on, and it's not to be used for bereavement. So if the stressor is that a person has passed on, we're not going to diagnose them as having an adjustment disorder. This is also fairly short term, so we're looking at no longer than 6 months after the stress situation happened. Just like in all of the other trauma and stress related categories, we're looking at the increased risk of suicide, so always make sure you're assessing for that. We think of this as fairly common. So this is actually a category that people use a lot of times before they really know how to diagnose someone. So if you're just starting to see a client, you know that they're reacting to something that happened in their life, but you don't really have enough information to give them an anxiety disorder or a PTSD diagnosis. This is something that might be appropriate to list first, and then when you get more information, you can change it to the other diagnosis. And one of the reasons why people tend to like this is there's not necessarily a lot of stigma that's associated with an adjustment disorder. So everyone has stress situations in life. This is short term. It's not a very major disorder. So it's something that you will see fairly often used to code so you can start billing for insurance purposes before you really have a more concrete diagnosis. Or if it's something that's not maybe not too serious, or maybe you don't want to put that label on, this could be enough to do the billing to get you started. Okay, so we're looking at this not related to other health disorders, but it doesn't mean that they can't co-occur, right? So you might have someone who has, say, schizophrenia, but they're also having adjustment issues related to being kicked out of the home that they lived in. So they can be related to each other. It can also be related to a medical disorder. You might see situations where a person's having an adjustment disorder because of a medical diagnosis that they've received. So if they've received some kind of news that their physical health in their life is threatened, they might have an adjustment disorder related to that. So I hope that makes sense. This is one that you're going to also use a fair amount, and that you're going to be able to kind of use and then adjust as you need to a different diagnosis. Okay, so our dissociative disorders, those are going to be characterized by the disruption or discontinuity of the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. So that's a lot of things. You're going to see this after some kind of trauma has happened, which is why it's very close to the the trauma and stressors category in the DSM. So the one that you're going to hear about the most, but you're not going to see the most, dissociative identity disorder is what we used to call multiple personalities. So the main thing that you're going to see for this is 2 or more distinct personality states. People might also call this that they feel like they've been possessed at some point. And this is not part of a cultural or religious practice. So that's something that you're going to want to screen if you're working with people from other cultures. Pretty much anyone with a dissociative identity disorder is going to have a long history of trauma or traumatic events, especially forms of abuse during childhood. And this tends to be pretty severe abuse, so this is not necessarily one situation that's happened. It's usually repeated and long-term, something very overwhelming. And usually what happens is when that person has that traumatic situation happen as a child, their brain does this tricky stuff where they're kind of closing down one part of the brain and letting a different part take over to protect the core person or the core personality inside. So you often see kind of a tougher personality emerge, or perhaps an older personality. You might even see a younger personality that's very innocent and doesn't know what's happening. So different ways that the brain is trying to cope with that traumatic event happening. You're going to see, this is a pretty severe diagnosis, so you're not going to see a lot of this. If you do see this, you're probably going to have multiple diagnoses going on at the same time. So you might have variations of a depressive or anxiety disorder. Substance use is going to be fairly common. Self-injury is very common. You might see seizures. So you're going to want to make sure that you're looking at all these different areas. You're also going to continue to do that very careful screening for suicidality. This is going to be another area where, think of all the trauma that's happened, you're going to have a lot of an attempted suicide rate, so over 70%. One of the patterns that you're going to see if you do happen to work with a client with disorder, and I actually haven't, not very many people have, is that the individuals try to hide their memory loss. So they're going to try to do whatever they can to cover up the fact that they don't remember what happened for a couple of days or a month or whatever it is. So they might say, oh yeah, I remember when we saw each other last, and be very vague about it because they actually don't remember that they ever met you, perhaps. So that's going to be really common, that they don't want to admit that that happened, or they don't want to admit that they can't remember. The book and the movie Sybil is a really good example of this. So if you want to do a little bit more of outside reading, something that's not a very pleasant book to read, but gives you a really good example, that's a good one. The United States of Terra, if you can get that on Netflix, that's also a good example. That's a little more lighthearted and fun, but they both show you some examples of how completely different the personalities can be when you're looking at someone with a dissociative identity disorder. Dissociative amnesia is probably something you're going to see a little bit more often. So it's usually going to be seen as the inability to recall important biographical information that you would usually be remembered. Usually it could go one of two ways. It's either selective for a specific event or generalized for a certain period of time. So you might have an example of a kid who had some trauma when they were, maybe it was for an extended period of time when they were 6 to 7, and they don't remember anything about the year, they don't remember what house they lived in, they don't remember their parents at that time, they don't remember the big trip that they took to Texas or whatever it was. So that entire year is just missing from their life. That's a fairly common example. It might be a fairly sudden onset, and they might have multiple episodes, so it could be fairly common that this comes back. There's different periods of life that people don't remember. So that's pretty much what we're going to see in the dissociative area. It's going to be one of those two, and what you're likely to see is the dissociative amnesia category. You won't see as much with the other one. Somatic symptoms and related disorders. This is our newer category. It's new to the DSM-5. And the common feature is going to be that somatic symptom that's associated with some kind of distress or impairment. And positive symptoms and signs just means that you're actually seeing something that you is kind of tangible as a new thing. It's a positive symptom is something that you can describe it happened, not a lack of something happening. So a negative symptom might be suddenly not being interested in anything, where a positive symptom might be that stomach ache that someone has or the anxiety attack that someone has. The somatic symptom disorder is usually going to be some kind of physical symptoms that are distressing or result in a significant disruption of daily life. And they might have more than one, or it might last for a period of time. So for most people, it's going to come across as pain. So it's going to be some kind of pain. Their stomach hurts, their back hurts, their leg hurts. Maybe they can't walk because their legs hurt. Something like that. You might also see some people where it's a little bit more generalized, where maybe they're just always tired. And the key part for this is that there's no medical condition causing that physical pain or that fatigue or whatever it is. You might see cognitive issues related to this, so being worried about being sick, maybe because they have back pain, they're afraid that doing any kind of physical activity is going to cause back pain. Something like that's very common. You might also see a depressive symptom together with this. So you can imagine if we're looking at long-term pain or long-term fatigue, that's going to be something that very easily could cause depression. For kids, you're usually going to see abdominal pain, headache, fatigue, and nausea. You're also going to be looking at the setting in which this happens. So if it is something like the kid always gets nauseous when they have to go to school, that might actually cue you to look at what's going on at school and see if that's something that needs to be adjusted or ruled out. 5 to 7% sounds a little high for a diagnosable version of this. I think we all have somatic symptoms, right? So everyone has an event that they're dreading doing so that they get a headache. That's a somatic symptom. But to be a disorder, it's going to be something that's resulting in that significant disruption of daily life. So it's ongoing. Maybe you're getting that stomach ache every time you have to go to work to the point where you don't feel physically able to work. So that's when it would be disrupting daily life as opposed to one event that you're nervous about so you get a stomach ache. You might also see illness anxiety disorder. So that's when people are so worried about getting a serious illness that they actually start to feel the symptoms of that illness. Or it might just be them being so worried about getting an illness that they start avoiding or altering their daily activities. So you might see examples of people who will never touch anyone else, who won't sit at anyone else's desk because they're afraid that the germs are going to make them catch the bird flu and then they're going to die. So it has to be serious enough so that it's affecting the daily activities. So it's something that I don't think you'll see a lot, but it's something that you'll see enough to be aware of. Facetious disorder is something that you hopefully won't see too very often. I haven't seen this one diagnosed. So we used to call this Munchausen. So that's when you're actually faking an illness. So falsification, medical or psychological symptoms. You're going to see behavior to conceal the disorder and a lot of deceptions. So you might even see people seeking treatment for an issue. So they think that they have cancer or they want people to believe that they have cancer. So they're going to falsify some medical records to show that they have cancer, and then they're going to try to get treatment for cancer. And this is something that you usually see multiple episodes for. What we used to hear a little bit about, and this is more something that you'll see in TV or in books, is it was called Munchausen by proxy. And that was when you would see an example of, say, a mother poisoning a child so that the child would have physical symptoms so that both the mother and the child would receive a lot of attention. So now we would call that facetious by proxy. Unfortunately, we don't see that too much, but it's something that you should be aware of does happen. And that is the end of our diagnoses for this week. So make sure you post any examples of times you've seen any of these disorders in either clients or people that you know, and any questions that you have about the disorders that we talked about this week. Have a great week.